A cluster headache is one of the most painful conditions known. They're characterized by attacks of severe pain that is unilateral around the eye and temporal region. The intense suffering that's felt in an episode is hard to convey, with some referring to them as suicide headaches. They usually occur daily during regular cluster periods that last up to several weeks once a year. Stick around to the end for some mnemonics to help you remember everything important. The cause of this condition is not known, but it's been associated with a history of head trauma, heavy cigarette smoking, and heavy alcohol intake. They've also been associated with structural lesions in the pituitary or surrounding areas, so requesting an MRI with pituitary views is advisable. The pathophysiology of this condition is complex, and we really don't know what occurs in the brain. Our current theory is that attacks occur due to the activation of the hypothalamus, causing a complicated interaction between the trigeminal-vascular pathway and the autonomic nervous system. There are three cardinal features associated with this disorder: headache, autonomic symptoms, and a really regular pattern of attacks. Symptoms most commonly occur in the periorbital or temporal regions. The headaches are sharp and stabbing in quality. As they're so severe, patients are typically restless and prefer to pace about or sit and rock back and forth during an attack. Remember, the autonomic nervous system is comprised of parasympathetic and sympathetic branches, controlling involuntary actions like blood pressure and sweating. A key feature of this disorder is parasympathetic activity in the trigeminal nerve, causing ptosis or eye drooping, miosis or small pupils, and conjunctival injections on the same side as the headache. Finally, these attacks occur with an extremely regular pattern, with bouts that persist for between 15 minutes and 3 hours. They're also known as alarm clock headaches, striking at precisely the same time each day during a cluster. Not only this, but clusters themselves often start at the same time each year. For example, a patient might have a 6-week cluster that starts each July and finishes halfway through August. Unfortunately, while most patients have this form of episodic headache, some suffer from chronic non-remitting attacks. When we're thinking about management, consider acute therapy options and preventative options. Acutely, a subcutaneous triptan is the most effective treatment for cluster headache. Sumatriptan is often used first line. Interestingly, patients with cluster headache also get symptomatic relief from using high-flow oxygen. This can be given with 100% oxygen at 15 liters per minute via a tight-fitting non-rebreather mask for 15 minutes. Preventative treatments may be used continuously for chronic headache or intermittently for episodic cluster headache. First-line prophylactic drugs include verapamil, topiramate, and sodium valproate. In predictable episodic cluster headache, it's prudent to just build up to a therapeutic dose in the month before the expected onset of headaches. Other non-pharmaceutical preventative options include neuromodulation, for example, occipital nerve stimulation, or deep brain stimulation in refractory cases. Remember the main features and main management with the following rhyme. Patients with on-the-clock, shocks, and lid drop need management plan of triptan and oxygen. This should remind you that cluster headaches have an extremely regular pattern of attack. They present with shocking, stabbing pain and autonomic features like ptosis. They require a triptan and oxygen as soon as possible. Thanks so much for watching Townsend Teachings. Don't forget to like, comment, and subscribe. It really helps.